speaker is going to be Ashvin AGARWAL, who's going to talk to us on pinhole pupilloplasty for the irregular corneas.
Thank you. So I'm going to talk about something new, something different, and how we can avoid a lot of the corneal-related irregular astigmatic issues that we all face in our practice. Just to start off, I do have financial interest with LSR, but it doesn't pertain to my talk. And okay, fair. Here you go. So basically, what we're trying to do is when we have irregular astigmatism, we are always trying to attack either the lenticular plane or the corneal plane. But let's look at a new paradigm where we are trying to attack the iris plane and trying to reduce or bring down the pupil size permanently, thereby reducing the chord mu length. What is the chord mu length? It is basically the visual axis and pupillary axis. The distance between that is the chord mu length, and that's what, when you reduce that length, it helps enhance the vision quality, enhance the vision crispness, and removes all the higher order abrasions from the cornea which is passing through. So it is based on certain principles which we call a Still-Crawford's effect. It's also the vignetting sign that we see in these cameras, who obviously have a lot of impact on this, and how the rods and cones behave in terms of light that's entering the eye. I'm not going to go into the principles too much, but the idea is also to give you investigations that you do in these cases are pentacam, retinoscopy, eye trace, which really helps, and I'll show you a few of those. The pinhole occluder, this really defines the customized pupil size that it should be for that particular patient, so it's customized for that patient. And you have the far, intermediate, near vision at different scotopic levels. Also the manifest refraction. This is on the left you see the pinhole occluder, which is basically what defines preoperatively. You place this in front of the patient's eye, and the patient then defines where, let's say 1.5 or 2 millimeters is the patient seeing the best quality of vision, which is what you will replicate on the table. On the middle you'll see the RMS value, which is the root mean square value of the higher order aberration. This is seen on the pentacam. You'll obviously have to go into the pentacam and see this. You can find this at the pentacam level. The normal value is 0.33. In this particular case it was 13.08. So what I'm trying to show here is any higher order aberration of more than 0.5, even more than, if you want to be a safe bet, more than 1, just go ahead and do a pinhole pupilloplasty. You'll be shocked with the results. That's what we're trying to ascertain over here. In an eye trace, you can see the level of astigmatism. I only want you to look at the circled images, the 1, 2, and 3. That is the millimeter of light entering the eye. So that's what we're trying to showcase over here. At 1 millimeter pupil, the astigmatism is dropped down. At 2 millimeter pupil, the astigmatism goes up, and 3 millimeter pupil, you have more and more as light entering the eye is directly proportional to the astigmatism of the eye. That's what we're trying to showcase over here. These are the instruments when you want to do this procedure. It's rather simple. It's actually just sutures is what you need, and your own skill. It's intracameral sutures, which we use 9-0 or 10-0, whichever you have. The technique that is used is the single pass 4th row pupilloplasty technique, which we all know is pretty simple, and it can be done repeatedly with less trauma, less inflammation, less iatrogenic issues that can come up in these pupilloplasty scenarios. But just you have to do them multiple times. That's the catch here. So here's case number 1. I'll show you some cases where this is a post-DALC patient where the astigmatism was off charts. Otherwise, I would have had to do a repeat PK in this patient. But no, we decided to go ahead and do a pinhole pupilloplasty, 4 of them, so that we can bring this pupil size down. Now, what happens is when you bring this pupil size down, it becomes a cat eye. So you need a vitrectomy system also, so that you can open up that pupil and make it circular to hit the first Purkinje image. And this is, guys, post-op day 1 without glasses. So this is post-op day 1, the post-DALC patient, which I would have otherwise had to do a complete PK. And that's what we try to avoid in this case. This is a second case, which is a 20-year-old back, LASIK done. Look at the striae. You can see the striae, and you can imagine what the patient must be going through on a daily basis, because the pupil size is continuously changing. And what we're trying to do is This is the worst case scenario cases, guys. This is not your run-of-the-mill everyday kind of case. So these patients are very, very unhappy. They have been for 20 years suffering with that striae, and what we're trying to do is don't touch the cornea because we don't know the result of how that healing process will be. Here we are giving a very sure form of success rate, but you got to get the technique where you close the pupil size down and then open it up, because it will become cat eye. You open it up and make it a circular 1.5 or 2 millimeter. The visual, what I tried to show in the last images of this video was you can even get a really good field of vision. It does not hamper the field of vision. I know a lot of questions will be asked on that, and I'll come to my most obvious question, which we'll come to. This is a post-RK patient. Obviously, I've removed the conjunctiva so that we can avoid any incision expansion because of the RK wound. Obviously, in these cases are again terrible corneas because you have a very irregular astigmatism in these cases. The easiest and the format we've seen in these cases is to do a pinhole pupilloplasty, and it removes the issue in these cases. Just in interest of time, I'm going to show you. This is 2 weeks post-op for same patient, and this is the fundus image after the pupilloplasty. That's what I wanted to tell you. Obviously, there's one question now everybody's in the room will ask me is, how do you see the retina? The retina is, I just showed you the last image, that was Mirante. I use Mirante. I have no financial interest with them, but I use the Mirante, and that's one of the techniques that you can use to remove irregular astigmatism from your, use it in your practice. Thank you so much.
Thank you, Ashvin. I have one more question. PCO, I saw in one case you had some PCO and you do the pupilloplasty. So do you take care of the posterior capsule first?
Yeah,
before you do the pupilloplasty?
Yeah.
So
have
you
to
open
do
the posterior capsule?
Yes.
Yeah, okay, yeah, that makes sense.
Absolutely.